Okay, it is 1 o'clock Eastern Standard Time, and this is Dr. Mitchell Yass with another attempt at a YouTube Live video. I think this time I finally got it right, and the link that I sent out actually is where I am presenting this YouTube video. So, YouTube Live video. So anyway, thanks for joining me, and this is a segment that we will be talking about why people are still suffering from chronic pain in such mass numbers. In the United States, it's estimated that 130 million Americans are suffering from chronic pain, while roughly 1 billion people worldwide are suffering from chronic pain. And I believe that there's a massive confusion as to this reason. And for most people, the perception is that they have just not gotten the right treatment. And that is why they continue to suffer with chronic pain versus getting the right diagnosis. And I think people have to understand that the problem is that they're not getting the right diagnosis from the inception of their entrance into the medical system. That is where the problem lies. So what's going on is that you have some symptoms, and typically the symptoms reach the point at which you're having some sort of dysfunction, some inability to perform a functional task. You can't go up a flight of stairs. You can't kneel down. You can't sit for a period of time. You can't work on a computer. And eventually, it's usually at the point at which that lack of functionality occurs to where you then seek medical attention. So you enter the medical system, and I think most people would acknowledge that the use of the MRI or X-ray is the primary mechanism for diagnosing the cause of pain. I've had innumerable people tell me that you're probably not with the doctor more than 3 to 4 minutes, which is just enough time for the physician to actually ask you, where are you having your pain? And therefore, that's where the prescription for the MRI will be written. That's the point or the location where they'll want the MRI performed. And then you wait, and then you get the results back, and then you're brought back in, and you discuss the results of the MRI. So for instance, let's say that you're having lower back pain. And I've recently just got 2 emails just in the last 2 days of 2 people who were performing activities, ended up having a substantial amount of back pain after it, and is now seeking medical attention. So, of course, they're referred for an MRI, and the MRI is going to show a herniated disc, stenosis, arthritis, a pinched nerve, spondylolisthesis, any of the typical types of structural variations that can be found. And because the MRI has been performed for the first time, and these structural variations identified at the time you're having your symptoms, it is asserted that they are the cause of your symptoms. And that is what is known as correlative theory, which is also known as junk science. And what it says is that if something happens while something else is happening, I can say this thing is causing this thing. A good way to think about it is the idea that if I open my front door when the sun rises, I can now say opening my front door causes the sun to rise, which is clearly an absurd premise. But because one thing happened at the time the other thing's happening, the assertion is made one is causing the other. So in this particular case, since a herniated disc, stenosis, or arthritis at the back, arthritis or a meniscal tear at the knee is found, arthritis or a labral tear at the hip or the shoulder is found, these are asserted to be the cause of your symptoms. And it is simply baseless to make that statement. And you can see it in a couple of different ways. Number one, the MRI would clearly show at the time you're having your symptoms that you have 2 elbows. I don't think anyone would deny that the MRI will show that you have 2 elbows, but clearly no one would surmise that since 2 elbows are found at the time you're having your pain, that that's the cause of your pain. Well, why would you think that the assertion that just because a herniated disc or stenosis or arthritis or any of these things were identified at the time you're having your pain, that they are the cause of your pain? Right? So you could clearly see that based on the idea that, well, if 2 elbows isn't the cause because it's found, then you can assert that those structural variations are the cause. But then you can take it to a further step. So let's say that we look at this idea that these structural variations are the cause of symptoms. Well, if that's true, then what would you expect to find for people who don't have symptoms? Would you expect them to have structural variations? And the answer would be, well, if structural variations cause pain, because that's what's being asserted to you, then people who don't have pain should not have structural variations. And in 1994, the very first study on a group of people, was 98 people who had absolutely no back pain, was performed, and it was found that 70% of them have bulging or herniated discs. Hey, Sherry. Oh, thank you for listening. I'm glad you're on. Sherry's mentioning she had failed back surgery. Doctor told me I had a herniated disc and I was still in pain after surgery, which she brings up a very viable point. So if in fact these structural variations are the cause of symptoms, why are surgeries on them to resolve your pain failing at such a miserable rate? And you can see that in studies that have shown that 70 to 80% of all back surgeries failed. So much so that that exact concept is what happened, that they derived or designed a new diagnosis called failed back surgery syndrome for those people who had surgery, and the symptom was exactly the same after the surgery as before. And just think about what that diagnosis means. Think about how scary that premise is. Failed back surgery syndrome. The doctor who did the surgery is saying to you, I'm giving you a diagnosis that says that I performed a surgery that has failed to resolve your symptoms, and I don't know the cause, which is what the phrase syndrome represents. The phrase syndrome implies a group of symptoms without an understanding of a cause. So this gentleman or woman who just did surgery on you is acknowledging that they don't understand what's causing your symptoms after they perform the surgery, but they want this new diagnosis to allow them to continue to treat you. That should be a fairly scary premise. Vicky Roberts writes, please give us your email before ending your video. You helped my niece on the Georgia coast to avoid surgery a year or two ago. Wow, that's fantastic. I have a painful issue I would like to reach out to you about. So actually, what I'll do is, just to get that there, I'm going to actually type it in, email. There you go. Okay, so if anybody that needs my email address, I just put it in there. Sherry wrote, I also have had many failed epidural shots that didn't work. Again, we're looking at this idea. So let's say that you were told that you had this structural variation as the cause, and it's not. The evidence will be clear that as many people with no symptoms have the same structural variations in the same percentages. And therefore, what that means is that the structural variation is actually an independent variable, means that it's separate to the cause of your symptoms. It exists. No one's denying that. I'm not saying you don't have arthritis. I'm not saying you don't have herniated disc. But that herniated disc or arthritis or spondylolisthesis is not eliciting a symptom, and therefore warrants no treatment. You need to identify the tissue in distress that's eliciting your symptom to resolve the distress of that tissue. The symptom of pain is actually an emergency distress signal from the tissue trying to create conscious awareness to you so that you recognize that it's in distress and you can perform an intervention to resolve the distress. Once that happens, that tissue no longer has to elicit this emergency signal of distress, and it stops. So the way you stop a symptom is not to address the symptom, because that's just a signal. You're trying to address a tissue. And I don't think everyone understands this idea, that when you get a diagnosis, the diagnosis has to incorporate a tissue. So there's massive numbers of people who get into car accidents and they're told that their diagnosis is whiplash. Whiplash is not a diagnosis. It's a representation of a mechanism. Unless you could identify the tissue, a bone, a nerve, a muscle, treating for whiplash is just a meaningless statement. It doesn't really mean anything. Just as in Sherry's case, epidural nerve blocks don't mean anything. what is the tissue that is supposedly being treated when you are getting an epidural nerve block? No tissue, no tissue. It's just an attempt to mask your symptoms, block your brain's awareness of the symptoms. But the actual symptom itself is still continuing to be elicited. I don't think anyone could deny that. It's clearly still being elicited because there's still a tissue in distress. And what happens when that medication wears through you? Because all medications have to work through your body and eventually they work their way out. Well, that tissue is still eliciting symptoms. And so at some point, you'll just get the very same symptoms back. And I think people seem to often get confused by this. They think that somehow the cause of their symptoms was addressed because the epidural nerve block stopped them from feeling it. And then they're confused when the symptoms come back. But all that happened was it's the equivalent of you have a fire, your fire alarm is going off, and you just take the battery out of the fire alarm. And you say, you know what? It's just so annoying that sound is irritating me. You know what? I'm going to stop it for an hour. But you don't do anything about the fire. And then in an hour, you say, you know what? I'm going to throw that battery back in. And boom, it goes off again. And you're confused. I don't understand what happened. You didn't address the cause. The same thing can be said for the way that the system treats your symptoms when they get the wrong diagnosis by the use of the MRI, which is simply finding structural variations which existed for years, if not decades, before your symptoms began. Now, if you understand the idea that symptoms are the representation of a tissue in distress at the inception of distress of that tissue, you would have to recognize that the symptoms begin when the distress begins. So if you were to acknowledge that MRI is finding something that's probably degenerative, that has been there for years, if not decades prior, how can you say that that is the cause of the symptoms? The symptoms would have had to have begun at the time of the distress of the tissue. So if it was an arthritis, and it's acknowledged that arthritis has probably been there for years, you should have been having pain for years if the arthritis was causing the symptom. You can't say that 2 weeks ago you started getting pain, but some massive level of arthritis, which is clearly developed over decades because it doesn't grow that fast, it's actually slow and progressive, right? That could have began 2 weeks ago. Now someone's going to try to come to you and say, oh, but the arthritis has progressed. That's what's happened. The arthritis progressed to the point where now it's eliciting the symptom. Well, what if I told you studies have shown that there's actually not only a correlation to arthritis and pain, but to the severity of the arthritis, to the severity of the pain. There are people who have massive levels of arthritic change who have virtually no symptoms. And then there are people who have very, very little structural variation, arthritic change, and massive amounts of symptoms. How do you account for that if arthritis is in fact the cause of symptoms? Vicky writes, thank you very much. I'll complete an email after your live stream. Thank you, Vicky. That's great. I appreciate it. Anytime anyone comes back to me and tells me that I've had an impact on resolving their pain and having them be able to achieve the quality of their life that they're looking for is always a very humbling thing to me. Sherry has known me since my days when I had a physical therapy facility back in New York, which I had from 1997 to 2012. And she knows how personally I take this and how much it means to me, because I think that my methodology is so unique. I came up with this after I went to medical school. I got the same physical therapy training that everybody else has, and I got a doctorate in physical therapy. But I just saw that it really didn't attempt to connect the dots between symptoms people are having and the potential causes. And what you have to truly believe is that the symptoms are being elicited by a particular tissue. Therefore, those symptoms are representative of a specific tissue. So a bone will make a very specific type of symptom. A nerve will make a very specific type of symptom. A muscle will make a very specific type of symptom. Your lung will make a very specific type of symptom. Your heart will make a very specific type of symptom. So if you're not attempting to look at the body's presentation of symptoms through a physical presentation, then how do you identify what tissue is eliciting the symptoms? Does anyone think that when you go to the doctor and you get that MRI, that they're actually looking at you, they're doing a complete physical evaluation to look at your symptoms to identify where the symptom is? Is the symptom referred or is it point tender? All the things that would help tell you what the tissue is that's in distress. Is that what's happening when you go to the doctor? Or is it simply, here's the MRI result, this is what I say the cause is, this is what we're going to treat? Myra wrote, he is available through Skype sessions as well. That's an important point that I should make, is that certainly I understand the coronavirus concept, the isolation, the social distancing. I got it all. The great news for anyone who's looking for the Yass method is that I have been utilizing Skype sessions now for 5, 6, 7 years at least. And there's a justification, a rationale. Why, you could say, why has this guy been doing this for so long? Well, because my books are published by Hay House, which are published here, Canada, England, Australia, India, and South Africa, and because I write for What Doctors Don't Tell You, which is a magazine sold in 20 countries and translated into 14 languages, there is a certain international recognition of me and my method, and people have recognized that locally they're not getting the type of care that allows a proper diagnosis to develop and a proper treatment. It doesn't matter where you are globally, the methodology is the same. So as a result of that, people have contacted me, and I don't expect anyone to come very long distances, especially when the Skype evaluation is a very, very effective tool. Barring my ability to palpate, which is to touch a tissue to confirm it is the tissue in distress, most of the other aspects of the physical evaluation can be performed in the Skype session. So it's a very highly effective means of getting the right diagnosis. Now, let's just talk about this concept. I'm going to tell you, and I don't think anyone on the planet is going to tell you this, 98% of cases of people suffering from chronic pain, it is a muscular cause. It is a muscular cause. The tissue in distress is muscle. Let me explain to you how it presents that way. You could have a muscle in distress that's simply strained and eliciting pain. So let's say the person who has the pain right here. This is known as the levator scapula. This is a muscle by name, levator scapula, elevate the shoulder blade. This is not a cervical spine muscle. This is actually a shoulder muscle, shoulder bladed, levator scapula, elevate the shoulder blade. So it's actually connected to the shoulder blade and relates to shoulder function. So if you had pain here and I could press on the muscle and confirm that is in fact what's eliciting your pain, you would have to understand that that's actually connected to shoulder function. And most likely there are other muscles involved in shoulder function which have strained first, causing the levator scapula to break down and strain. So that's a muscle that's eliciting a symptom. Then we could talk about pain around the kneecap, often described as caused by a meniscal tear, bone on bone, all this type of stuff. That kneecap's position in the groove that it runs through as you bend and straighten your knee is determined by a tendon above the kneecap, which attaches it to the quad tendon, to the quadriceps muscle. That's the muscle that sits on the top of your thigh. Well, if there's some variation in force of that quadriceps, maybe it's strained, maybe it's become too strong in relationship to the posterior thigh muscle, which is the hamstring, which alters the force on the quad tendon, which positions the kneecap. Well, if that kneecap is positioned improperly as it runs through the groove, it's going to alter the way it runs, and it's going to rub in a way that it shouldn't, leading to knee pain. But because the pain is at the knee joint does not reflect the fact that you have a structural variation of the surfaces of the joint, it doesn't matter if arthritis was found. If, in fact, it's a muscular deficit, which is causing the joint surface to rub in an inappropriate way, you're going to have pain at the joint. But it doesn't matter how many knee replacements you get or how many knee revisions. If it's a quadriceps problem, a muscular cause creating a joint-related pain, you're going to have to fix the muscular deficit, which is to say stretch the quad if it's too strong in relationship to the hamstring and strengthen the hamstring. The scary part and the dangerous aspect of this whole situation is that I've treated thousands of people who have gotten knee replacements, were no better, if not worse, after the surgery, finally found out about me, because unfortunately I always seem to be the last resort, not the first resort, because simply I'm just not known compared to the global medical system. And so I do an evaluation and I point out to them, well, the pain was around your kneecap. I was able to confirm through a physical evaluation that your quadricep is much stronger. Flexibility-wise, I can show you that your quadricep is much shorter than it should be, which is the result of the muscular imbalance. And all I've done is massage out the quad, stretch the quad. The person stands up, their pain is gone. Just think about what that means. They've gone through one or more surgeries they never needed. It's led to a massive alteration of the structure of the joint, all the pain, all the suffering, because nobody did a physical evaluation to interpret where the symptom was and what the potential causes can be. Remember, this is a muscular cause. Can that muscular cause show up on an MRI? The imbalance of the quad to the hamstring, can that show up on an MRI? No. Can that muscle strain, the levator scapula, show up on an MRI? No. What if you're having altered sensation in your hand and you notice that this occurs after you've been laying on your shoulder, sleeping on your side at night? Well, because it's an altered sensation, boom, you're going to go right to the cervical spine. They're going to do an MRI, and they're going to find a herniated disc. And since the herniated disc was found while you're having that symptom, that's the cause. Wrong. Wrong. That representation of laying on your side is actually a representation of the fact that your rotator cuff is strained and you're having difficulty keeping your arm bone in line in the shoulder joint while you're laying on it, and it's being drawn forward, which is overstretching your rotator cuff, leading to it referring a symptom to the hand. So what do you learn? Muscles can refer symptoms, not just nerves. Muscles can refer symptoms. All you have to do is Google trigger point charts. Pick a muscle, Google trigger point chart for that particular muscle, and you'll be able to see exactly where, if that muscle strains, where it may refer a symptom. And sure enough, the infraspinatus, which is a muscle that sits on your shoulder blade, can refer symptoms all the way down to the hand, represented by the activity of laying on the shoulder, overstretching that muscle. So muscles can refer symptoms. The fourth concept of a muscular cause is a muscle impinging on a nerve and the nerve referring a symptom, which is sciatica. I think, let me just look at real quickly. We have Sherry, in order to his method to work, you have to be willing to do the work. Good, yeah. So the whole essence of what I'm trying to convey to you is that there are muscular deficits that are leading to this. And Sherry's bringing up the point that if you stay in the existing system, what's the ultimate goal of the existing system? Or certainly what's the way that it works? It tries to incite in you the idea that you have a structural variation creating your symptom. I don't think anyone denies that. Herniated disc, stenosis, arthritis, meniscal tear, labral tear, any of these types of things, right? And the failure rates for all this have failed so miserably that people are very hesitant to get them. So all you're left with is the idea that they're going to just keep giving you masking agents. It could be pain medication, epidural nerve blocks, cortisone shots, right? But as long as you're willing to accept this idea that it's a structural variation, who can fix the structural variation ultimately? Who can make the tissue in distress supposedly go away so that it's not in distress? Well, only the medical system, right? But what if it's a muscular cause? What if it turns out I'm right? And that knee pain around the pain around the kneecap is muscular. Well, that's indicating a muscular deficit, weakness, or imbalance, ultimately resolved through the use of strength training, progressive resistance strength training, whereby a muscle does an activity, a particular exercise, and the muscle is trained to work against a greater and greater resistance, to where the muscle develops enough force output to where its output is greater than the force requirement of your activity, which leads to its ability to perform the activity without eliciting a symptom, right? So that's the concept behind this. Well, can I make you stronger? We just had this discussion, actually, Sherry and myself, right? I can't make you stronger. Only you can make yourself stronger. So what is it that's limited you this 10 years or 20 years or 30 years that you've been struggling with chronic pain? Number one, you didn't identify that you had a muscular cause. Number two, you didn't know which muscles were involved when you identified it as a muscular cause. Number three, you don't know how to do the exercises for any isolated muscle. And number four, you've never been taught how to do progressive resistance exercise, which is to cause the muscle to adapt to greater and greater resistances. Well, once you get that from me, and I've given you all of that information, what's left to do? 3 times a week, perform the exercises in a way where you're attempting to progress the resistance over a sustained period of time. You get 3 to 4 progressions of resistance. Now the output of all your muscles is greater than the force requirement of the activities. You're pain-free and fully functional. Who can make that happen for you? Me? Not me. I'm just a teacher. Sherry will tell you I'm a bit of a motivator, philosopher, theorist, all that stuff. But ultimately, I'm just a guy who can give you the tools to allow you to make yourself better. If, in fact, it is confirmed to be a muscular cause, which I pretty much can guarantee you is the case in 98% of cases. Over these 27 years I've been doing this, what I have found is that people have come to me with a diagnosis from some physician, typically based on a diagnostic test, and I have been able to show them that if, in fact, that structural variation was in distress, the location of where that symptom should be is not even remotely in the location where the person is actually having their symptoms. That is the final and absolute red flag to the failure of this system to identify the cause of pain. I'll give you the greatest and simplest example. A person is having groin pain, pain in the inside of the thigh. They get an x-ray that says that the cause of the pain is coming from a arthritic change in the hip joint. Now, most people seem to not be understanding where the hip joint is. So if I can kind of just briefly stand up, this is my hip joint over here. It's all the way over here. It's not in the groin. It's not at the top of my pelvis. It's on the side, all the way down here, really at the bottom of my hip pocket. Okay? So if that's where my joint is and someone is saying that the groin pain is coming from that, that is to say that I would have to lay you on your side, push on the joint, force the hip joint, the hip bone into the socket, and see if I can bring on your groin pain. That is what is known as a referred symptom. The symptom at the groin is coming from another location, referred from the hip joint. And I've done this thousands of times. And you can press as hard as you want, do whatever you want. You're never going to get it from the hip joint. Yet, if I then go into the groin and press on a muscle, and you have the symptom and I can exacerbate the symptom, then I have proven that the tissue I'm pressing on is in fact the tissue that's eliciting your symptom. And since it's in the groin, what sits in the groin but muscles? The sartorius muscle, the gracilis muscle, the psoas muscle. So if I did an attempt to address your physical presentation and was able to show you that if I press in your groin, I can bring on your symptom, but if I press on the hip, I cannot bring it on, I have irrefutably proven that the cause of your symptom is not referred, but in fact, point tender. That ends any person's attempt to tell you that that x-ray has validity, or that MRI has validity, or that arthritic change, whatever level it is that was found in the hip, has anything to do with your symptom. I don't give a shit if you got 10,000 hip replacements. If that pain is due to a strained sartorius muscle or a strained gracilis muscle, until you establish why that's straining and resolve the muscular deficit, you will have pain forever. Just look around. Find out who's had hip replacements. How many people after a hip replacement have you seen do that stupid wobble thing? And it used to be that supposedly that was the person who hadn't had their hip replacement. That goes 10 years back. And it was actually the wobbling is actually due to a muscle on the side of the pelvis called the gluteus medius, which is having difficulty keeping your pelvis level while you're single leg standing. And as a result of that, you're just shifting your weight to the other side so it doesn't have to work. Well, this false premise that the joint was the cause of your symptom has now led people to get the hip replacement. And guess what? It was the glute med the whole time. So now the post-surgical symptoms of pain and swelling have brought the symptom on worse because it's harder for the glute med to support you. So getting that surgery is the very reason why after the surgery you have increased symptoms, not just of pain, but the inability to function. That's what's going on in the world today. That's why everyone's suffering from chronic pain. It's misdiagnosis. I started this off and titled this, it is the wrong diagnosis that is leading to your chronic pain, not the wrong treatment. Let me just catch up real quick. Myra say, yes, it involves doing the exercise as Dr. Yass. I have been doing my exercise 3 times a week, put in the work, and the outcome is a positive. And in Myra's case, she had such a severe straining of her rotator cuff that it actually affected the mechanics of her arm bone. This is the shoulder joint. Her rotator cuff, a normal rotator cuff, is loose enough that the arm bone can drop down, the head of the arm bone, to allow you to raise your arm. Well, with her rotator cuff being so strained and shortened, it's not giving this ability. So she tries to raise her elbow, but the shoulder bone is stuck. So it impeded. She actually had a loss of range of motion. But not all losses of range of motion represent an arthritic or structural deficit. You must understand that all joints, the way the two joint surfaces move is by the mechanics of muscles pulling on those joint surfaces to move them in a certain way. So if there's some altered strength or weakness or an imbalance, it could change the mechanics. And you could have a joint that doesn't function properly, even a loss of range of motion, but it's not structural. In her particular case, I went there one time. We did an aggressive massage. I did a lot of stretching. We did a strengthening exercise to lengthen it. She picked up 40, 50 degrees of motion in one treatment. That fast. She had this, I think, for like 2 years, if I remember correctly. So let me see, Sherry. I've been to many other PTs that have failed to help me. Mitch is the only one who has helped me. Most people want the easy fix. That's the problem with the system. Right. I think Sherry's bringing out some very viable points. So let me just point this out. I have a doctorate in physical therapy, but I want it understood that this understanding that I utilize, this methodology I utilize, was not derived from my medical school background. This is mostly derived from the fact that I was a very, very thin kid, had severe self-esteem issues. I decided that the way I'd make myself feel better was by weightlifting. And strangely, I don't know who does this, but I took a high school physics course, and I started applying physics to weightlifting and started understanding what is the optimal force vector to create force against a bench press or a lat pull down, or what's the best way to stabilize my body on one side of a muscle so that I can maximize the force output on the movable side of the muscle. And this was way before I was a project manager in construction. That was my first career. This is my second career as a physical therapist. I went back to medical school at 30 years old. So before I went to medical school, had this understanding about mechanics. I had no idea that this was going to become the core of the methodology that I used to treat people to resolve their pain. That was never a thought in my mind when I started this. When I went to medical school, I was just going to be a guy who was a physical therapist, excuse me, and I was going to have maybe a place or two places, get married, have a wife and kid, and that was going to be my life. I really didn't know that I was going to get sucked into this as time went, and it really just kind of happened. And Sherry was there. She knew me from the very beginning. I was just a guy with a great practice. It was going well. Everything was nice. And I wrote a book and decided to get some local media. And Sherry actually got interviewed on one of those episodes. And before you know it, I got 25,000 calls to my office. And it was like a 6-month waiting list. And people started finding out about this guy who could diagnose whether I really did need that surgery or not. And I was in New York on Long Island, and people started coming from Buffalo and Albany and New Jersey and Connecticut. And people were telling relatives, and they were coming from Israel and from Ireland and from Greece, and it just blew up. And I started getting contacted from emails, and it just kept moving farther and farther nationally. And then I got the PBS special. That was in 2015, and that really started accelerating the national presentation and the presentation in Canada And then I started writing for What Doctors Don't Tell You, and that led it to a whole international thing. But the fact is that what I'm saying to anyone in the United States is the same thing I've said to someone in England, the same thing I've said to someone in Australia. They're presenting the same. It's not that I'm somehow putting everybody in the same boat. Everybody is in the same boat. You'll all have pain. You'll all seek medical attention. You all get a diagnostic test as the primary mechanism to identify the cause of your pain, and you all get misdiagnosed. The end. What happens after that varies based on who you go to, how quote unquote conservative they want to be. What is their surgery schedule like? Are they hot on the idea of trying to medicate you first and try to eventually wean you down to get the surgery? It's all a question of who you go to in that respect. But the fact is that they're all flying the same flag, which is that diagnostic tests identifies the tissue in distress eliciting your symptoms, and that's what should be addressed. And it's baseless. It's baseless. It's so scary. I just had a guy contact me. I'm talking about what country. Let me just show you what happens. So this guy contacts me, and on his note it says, "Please help me. You can save my life." And I'm like, wow, what the hell is this all about? That sounds pretty intense. And I read his email, and he actually sends me his MRI results. And basically, the MRI results is indicating that he's having some structural variations, but I guess at one point he had a symptom, but now he doesn't have any symptoms. And now he's panic-stricken as to whether he should get a surgery because supposedly he's got these terrible things happening in his joint, even though he doesn't have any symptoms. He's literally making himself insane. Literally becoming insane. He's so focused and obsessed because they describe these horrible words that sound like they must require some sort of intervention, right? They got to. And yet I'm having no symptoms. So do I do it or don't I do it? And the guy wrote me, actually followed up with another email. And this guy is just going berserk over nothing. So if I could give you a concept of a mindset, this might help to make you understand this concept. So right now, most people believe that when a structural variation is identified, especially with the scary words, spondylolisthesis, stenosis, all these things, that they are the equivalent of cancer, which is to say that when cancer is identified, it requires an intervention. So goes structural. If I find arthritis, you have to have something done with it. If you find stenosis, you have to have a labor. It must be done. Something must be done. Independent of whether you have symptoms, it's found, it must be corrected. I need you to understand that these are no different than wrinkles occurring on the inside of the body. Would everyone acknowledge that a wrinkle is a deformation of the skin? Clearly it is. Clearly it is, right? How come everyone doesn't go and get a skin graft every time a wrinkle is developed? Why doesn't that happen? The answer is because there's a general recognition that the structural integrity of the skin, what's the purpose of the skin? To prevent antigens from entering your body, right? That's why you have a skin. So although there's a structural variation to it, the integrity is still completely intact and the skin still works at the wrinkle. You still have protection against antigens entering your skin. Does everyone agree with that? Doesn't everyone agree with that? So what made you think that when arthritis is found, a herniated disc, stenosis, meniscal tear, compression fracture, what makes you think this is anything different? It's cultural. It's cultural. It's not medical. There is nothing medical about this. There is no medical evidence that would suggest that these, in fact, are doing something that require an intervention. All the studies actually show that doing nothing, multiple studies have shown that doing nothing gets you the same exact result as doing surgery in multiple types of studies. What do you think about that? What do you think that's saying to you? What that's saying to you is that these structural variations are not eliciting symptoms. That's why doing nothing gets you the same result as getting the surgery, right? So if it was the cause of the symptom, then getting everyone who gets surgery should have a reduction in symptom. Everyone who doesn't get surgery should have no change. They should have the symptom. And yet the results are identical. It's telling you that it doesn't matter if you had a meniscal tear when you had pain versus when you didn't have pain. That meniscal tear is not causing symptoms either way. The only difference is the person probably has some muscular deficit causing a pain in the muscle itself or a misalignment of joint surfaces at the joint, causing pain, which has led them to seek an MRI, which happens to be why the meniscal tear was found at the time they had the pain. But if they didn't have pain, say 6 months ago when they didn't have pain, if that MRI was done, what do you think you would find? The meniscal tear. 63% of people with knee pain have been found to have a meniscal tear. 63% of the people who don't have knee pain, 60% are found to have a meniscal tear. What's the answer? Are there symptomatic meniscal tears and asymptomatic meniscal tears? Are you nuts? Are you nuts? There's no indication of that. To make it even worse, for them, meniscus, labrum, and intervertebral discs are made of fibrocartilage. Fibrocartilage has no pain receptors in it. Everyone thinks that all structures, tissues have pain receptors in them. Bone doesn't have pain receptors in them, and fibrocartilage doesn't have pain receptors in them. Think of the logic. If your discs had pain, of all of you, think about when you jog or run. Maybe that's your hobby. You like to jog. Could you imagine the amount of pressure that's being applied to your intervertebral discs every time you run? Imagine you had pain receptors in there. Every step, you'd be complaining of pain because it's being compressed 3.5 times your body weight. You see the logic of it? These are the shock-absorbent structures. The meniscus, the labrum, and the intervertebral disc. So clearly it made sense not to have pain receptors in them, right? But they're found, degenerative changes are found, and because they're found at the time you're having pain, I guess that's the answer. Jean wrote, thank you for saving me from having a septic hip replacement. I still do my exercise religiously. Jean is a phenomenal student. She is spectacular. She is religious in doing her exercises. And it's a great story because she had kind of gone through the process and she got a hip replacement and they were talking about doing another hip replacement when she found out about me. So I got the opportunity to evaluate her on the second location. And based on the presentation of her symptoms, I was able to say, you know, and I'm not trying to disrespect anybody, but I'm simply basically interpreting your body, and based on where your symptoms are, I would say there's no way they're coming from your hip. And let me just show you how I know that. And let me just do a treatment to some muscles to show I can reduce your symptoms. And if I can reduce your symptoms, then if it was a hip replacement, if it was coming from the hip joint, how could I change your symptoms? And so, like on that first time, I greatly reduced her symptoms. And she's like, that's interesting. No one's ever been able to reduce my symptoms to that level. And within a treatment or two, it was fully gone. And that's when she woke up to the idea that I'm not saying that you don't have the arthritic change, but it is not creating your symptom. And I can tell you comfortably, there is no chance that that hip replacement would do anything to reduce your symptom. And what's so great with her is we really took this to an incredible level. And she ended up having some other areas that she had symptoms. She had a tennis elbow. She had a couple of things going on. And what was so great was she would just come out with another thing, and I would again evaluate the presentation of the symptoms. And then I would show her how I know through a physical presentation that the cause is in fact muscular. And then we would do some treatment, massage and stretching, and then we do some exercises, and there'd be this massive reduction in symptoms. And it was just an incredible experience to work with her because she had a variety of places. And we just kept going from one to the next and next. And then she started telling some friends about it. We We started having other people coming, and there just became this incredible line of people who now believed that there was an alternative to the existing system, that they don't have to believe that there's only one place to go, that clearly seems to have a baseless understanding of how to diagnose, and therefore you can't expect that you're going to get better from them. And most likely you're going to end up on some medication or simply being told there's nothing left that can be done for you. You're probably going to have to live like this the rest of your life. And I'm pretty sure this guy was one of the people that you said. It's really, I just got to tell you this really kind of crazy story because it really typifies what I'm trying to tell you about. So there's this guy and he's on a train and he goes to step off the train. And as soon as he steps off the train, he feels this massive pain in his knee. And he just hobbles. He can't do anything. And he has to struggle eventually to get home. And so he finally goes to his doctor. And the doctor does an x-ray. And he's like, oh, my God, you are bone on bone. You need a knee replacement immediately. And I think it was Gene who referred this guy to me. And so I check. Now, here, let's talk about this bone-on-bone thing. Here's the concept of bone-on-bone. An X-ray or MRI cannot identify if you're bone-on-bone. That's a fallacy. It's a lie. Because if you were, in fact, are bone-on-bone, that is to say zero space, zero. If you had a 32nd of an inch, a 100th of an inch, your joint would still function perfectly. So the question then becomes, based on an X-ray, an image that's being interpreted by an individual by eye, no microscope, no magnifying glass, could the human eye be able to differentiate 0 from a 32nd of an inch? And the answer is clearly not. The eye cannot see that. So by definition, that diagnosis is baseless because of the mechanism of using a human eye to interpret an image to determine whether there's any space or actually 0. So that's it. So that in itself was fallacy. So the only real way of determining if you're bone on bone is looking at range of motion. If you are bone on bone, the joint just can't move because there's no space for the joint surfaces to move, as I explained. Right? So the first thing I do with this guy is I check his range of motion, and it's exactly equal. It's full range of motion to the other leg, the unaffected leg, the one he had another symptom on. So immediately I say, you can't be bone on bone. I mean, you just can't. The physical presentation tells you that. And then I said, all right, I just want to feel around. I want to see if I can bring on your symptom because that's what's known as a comparable sign. If I can bring on your symptom and I can continue to bring on your symptom, it should hopefully you recognize that means I know what tissue is creating it because I keep touching the tissue and bringing on your symptom. So I press on his on the area near his knee, and I'm pressing on the attachment of his hamstring. Most people think of the hamstring as this muscle that sits in the back of the thigh, which it does. The belly of it does. But it actually wraps around on both sides and connects by tendons to the knee, kind of slightly in front, just below the actual joint line of the knee. So I press on its attachment on the inside, and he goes through the freaking roof. He goes berserk when I do this. And I said, oh, well, I guess that's it. So I keep pressing back into the muscle, and I'm now 3 inches away from his joint, and he's like, you are right on the spot. So what do you think happened here? Did stepping off the train onto the platform actually cause him to be bone on bone? Because think about what they're saying. They're saying that bone on bone has caused his pain, which is to say that you weren't bone on bone before he had the pain. The very moment before he stepped on that platform, he didn't have bone on bone, but now he does, and that's causing his pain. Or is it more logical that he stepped onto the platform probably in an awkward fashion? Maybe he wasn't paying attention. Maybe he was holding some luggage, and the force requirement of that weird movement was so great that it caused the hamstring to strain, eliciting this massive pain. And also, I believe he talked about a popping, and many people have talked about popping. But popping doesn't represent automatically substructural variation. It appears that when a tendon, which is the connection of the muscle to the joint, to a bone, when that muscle strains, it seems to create such a massive load that it changes the almost structural integrity of the tendon to where it seems to almost thicken. And I believe that's where the popping comes from. So sure enough, I just massage out his hamstring and stretch, and he stands up, and the pain is completely gone. And we do a couple of sessions of strengthening, and this whole episode is over, completely over. He never has symptoms again. He now fully embraces that he never needed that surgery, that he was in fact not bone on bone, and that what was needed was a proper physical evaluation, interpreting the body's presentation of symptoms to help identify what tissue was in distress, eliciting his symptoms. In his case, as I've said, it is in 98% of cases, it was a muscular deficit. The great part about these muscular deficits, I'm telling you now, Gene will attest to it, you're talking a couple of weeks of exercise and you should be able to resolve this in most cases. Of course, it does mean that you have to be doing the proper exercise, the correct exercise. You have to be doing the correct exercise correctly, and you have to be incorporating progressive resistance. So I've kind of talked about the idea of getting the right diagnosis, and that without the right diagnosis, all the treatments in the world will never work. And so can I just open the idea to you of saying that if you're having a symptom and you're seeking treatment and you're just going to someone who says, try this, and if it doesn't work, all right, but at least you tried it. You can't possibly see that as a very scientific model for trying to address your pain. I hope you wouldn't see that. I would rather you say to yourself, you know what? Before I get any kind of treatment, I really want to have a practitioner explain to me what the tissue is in distress so that I could feel comfortable. They'll have to explain through the presentation of my symptoms how they know that. And that way I would feel much, much more confident that the treatment that will follow is most likely going to address the correct tissue and therefore resolve the distress of that tissue, which will lead to that tissue no longer having to elicit the emergency distress signal of pain. I really would love. So this idea of, well, I can go to a chiropractor, I can go to an acupuncturist, I can go to a physical therapist, I can go to a pain management doctor, I can go to a podiatrist, I can go to a rheumatologist. I know they're all available. I got the concept they're all available, but what confidence do you have that that individual can differentiate from all the possible tissues in the area, that they can identify the correct tissue when all of these specialists are only educated to understand one tissue? So for instance, are you ever going to get a diagnosis from a neurologist that isn't neurological? Are you ever going to get a diagnosis from an orthopedist that is not based on the structure of the joint? Is a chiropractor ever going to tell you that the required course of treatment is to adjust the spine? Is a podiatrist ever going to tell, regardless of where the symptom is in your body, you're ever going to get something that doesn't say you need an orthotic or a cortisone shot? This is what you really have to understand. You really have to step back now. If you want to take part in the healing process, if you want to take part in the understanding as to what's causing your symptoms so you can take the right path, you can follow the same premise. You can, but you're just not going to lead it. You're going to just be another of the 130 million Americans and 1 billion people worldwide if you just follow the same process. I'm telling you that in most cases, this is about mechanics. This is variations to the forces as they apply to gravity pushing down through your body, which is what you're working against to allow you to do activities. A classic example, you could find 30,000 different remedies to plantar fasciitis, which is, if this is the bottom of my foot, there's a tissue that runs from the heel to the balls of the feet called the plantar fascia, and it has a tendency to become irritated. Now, you could go to a podiatrist and he's going to give you an orthotic, a cortisone shot. There's shit all over the internet of different things you can buy, liniments and mechanical things and all this other kind of crap. You may go to a physical therapist. They'll tell you to pull some marbles with your toes. What you're not attempting to understand is what has changed mechanically over some period of time, because there was a point at which you didn't have plantar fasciitis. So the question is, what's the mechanism that has now made the plantar fascia become irritated? And what you would suddenly recognize, if given the opportunity and looking at the physical presentation of your symptoms, is you're not walking the same. And you're not walking the same because somehow there's been a muscular deficit, which has led to an altered force that is changed how you weight bear through your foot. And as a result of that, there are stresses being applied to the plantar fascia, which weren't there before, and they shouldn't be there. So you need to look and try to understand, where's the mechanical deficit? What muscular deficit has led to this altered way of force running through your foot, which is overstressing the plantar fascia? Just because the plantar fascia is eliciting pain doesn't mean that there's something wrong with the plantar fascia. There's a higher probability that some force is being applied in a way it shouldn't. So it's the force application, not the tissue itself. The best example of that is the stupid bunion concept. The bunion concept is just the dumbest thing I've ever seen. So the person gets that excessive arthritic change, that arthritic bone development on the inside of the first metatarsal head. And it's very painful when they stand. But if they sit, they have no pain. As soon as they weight bear, they get pain. But if you don't weight bear, you don't have pain. And people are told that this is the bunion causing the pain, and therefore you need a bunionectomy. And I've had people who've had 4 bunionectomies, and the bunion just keeps coming back every 2 to 3 years. Come back, come back, come back. You got to say to yourself, what are you, just unlucky? You just happen to be unlucky. You just happen to keep getting that bunion. Think of the logic. If the bunion itself, the actual bone, was creating the pain, what does it matter if you're standing or sitting, whether you have pain or not? The pain would always be there because it's the bone. You just told me it's the bone. So it doesn't matter if I'm standing on my foot, if I keep my foot over the floor or over my head. What's the difference? The bone is causing the pain, therefore I should have pain at all time. If in fact the pain is coming from the bone. But you don't have that. You only have pain at the time you're weight bearing. Right? So if it's only weight bearing, then isn't it obvious it's the weight bearing that's causing pain, not the fact that it happens to be being elicited in the bunion area, in the excessive bone growth area? And so all you'd ever have to do is figure out what is it, and typically it's a weak hip muscle, which is not allowing you to weight bear through the midline of your foot anymore, which is causing you to weight bear excessively on the inside of your foot. So instead of weight bearing through all 5 metatarsal heads, balls of the feet, you're weight bearing only on the first metatarsal head. And as a result, that's what's actually led to the bone growth. Well, if you want to stop the bone growth and stop the pain, stop weight bearing only on the first metatarsal head and weight bear on all 5 metatarsal heads. And the only way to do that is to weight bear through the middle line of the foot, which comes from strengthening the hip muscle called the gluteus medius muscle. And I've done this, reproduced this multiple times. And there's an article I put in Bottom Line Health. I think it's on their website. I think if you go to Bottom Line Health's website, you would find that article that I wrote about resolving bunions. And I think there was another one that I wrote about resolving plantar fasciitis. That's actually my first book, Overpower Pain. So stop thinking that just because a tissue is eliciting a symptom, that means that it's some structural variation to that tissue that's eliciting the symptom. Most likely, it's a mechanical change, especially if you could associate your symptoms with activity. If you tell me that walking, standing, kneeling, climbing stairs, reaching behind you, any of these type things creates the symptom, brings the symptom on, or worsens it, you have just identified that you have a muscular deficit. I don't care where they're telling you the structural variation is. You have a muscular deficit, and it can only be resolved through targeted strength training, understanding which particular muscles are involved, and then using the appropriate exercise, which is not exercise found anywhere else. This is Yass. So actually, it's going to bring me to the next point. What makes, if we do establish that you have a muscular deficit, what separates Yass from going to the gym or going to physical therapy or anywhere else. What makes this so unique? Well, there's been a movement in the fitness industry that has created this thing called functional strengthening. It's the thing you see where you're turning the tires and you're moving the sled and you're doing the walking with the lunges. The thing you got to understand about all of that stuff is that that doesn't make any individual muscle stronger. Those are activity-based because it takes groups of muscles to perform them. So if you have a weak muscle and you're trying to do an activity exercise where groups of muscles have to do it, how do you isolate the individual muscle? You don't. You end up compensating. The other muscles that are strong will end up doing the work for the weakened muscle, which leads those muscles to strain. So there is no such thing as functional strengthening. It's a myth. It doesn't make any sense. Then you can talk about yoga, Pilates, aquatic therapy, all these types of things. Also, group activities, using groups of muscles to perform them. So if you're using groups of muscles, there's no way of isolating a muscle. Therefore, you cannot get that individual muscle strengthened. And in doing the activity, you will simply compensate, which leads to other muscles straining. So that's why these don't actually ever work in resolving deficits of pain associated with muscle. Yassercise is an attempt to figure out which particular muscles are involved in the dysfunction and allowing you to perform the exercise, which is simply that muscle. Every muscle moves one joint in one direction, and in identifying what that one joint is in that direction allows that muscle to only work singularly. Then you simply have to perform a level of resistance, which is greater than what that muscle's used to, which causes the muscle to adapt and get stronger. That is what Yassercise is. It is the use of individual exercises to strengthen individual muscles using progressive resistance to where the muscle on a consistent basis has to adapt to a greater and greater resistance, thereby getting the muscle stronger, growing muscle mass, to where the force out of the output of the muscle is eventually greater than the force requirement of your activities. This is what leads to the muscle being able to perform your tasks without straining. Okay, so that's what makes Yassercise Yassercise. It's been over an hour now. I thoroughly enjoyed this. Thanks for all the comments. It's been wonderful. If you want to get in touch with me, as I wrote in the message board there, you can reach me by email at drmitch@mitchellyass.com, drmitch@mitchellyass.com. If you like what you're watching, please subscribe to my channel on YouTube. The higher the number I get, the greater my position in Google, and it allows people to reach me with a greater ease. So please, if you like what you're seeing, please subscribe to my YouTube channel and also on Facebook at the Yass Method. Please like the page. I really want to try to help grow this and help reach as many people as possible. This is a global issue. Nobody is addressing pain correctly because nobody is willing to recognize and acknowledge that the primary mechanism for diagnosing the cause is baseless. You must end the use of the MRI and X-ray in the initial stage of diagnosing and treating pain. You must use a method that incorporates an interpretation of the physical presentation of symptoms, which is at the core of the Yass method. So please subscribe to this page. Please like the Facebook page at Mitchell Yass. If you need more information, again, Dr. Mitch at mitchellyass.com. You can see plenty of videos on YouTube, plenty of videos on Facebook. My website is mitchellyass.com. Go to the blog. 100 articles there as well. There's plenty of information you can get, which is free, to make you understand exactly what you need to do to use the Yass method to resolve your pain. Again, the Yass method is available in person, but right now it's not such a good concept. So Skypes are available. I do plenty of Skypes, and we can usually get them done within 2 weeks of the time that they're requested. All right. So for now, this is Dr. Mitchell Yass wishing you a pain-free, fully functional life. Let's work together. Let's end chronic pain globally. Bye-bye for now.